Well, good evening, everyone. Thank you for joining us, and welcome to our webinar this evening. My name is Oren Gargier, and I am the Director of Customer Success here at Zephyr. And I'll be hosting and moderating today's webinar. This webinar is going to be a little bit different than what we've typically held, and it's very exciting. So we're actually splitting this session into a couple of different parts. For the first part, we're going to have Dr. John Remmers speak about oral appliance therapy, treatment planning, and also, very exciting, he's going to be introducing you to our latest technology advancement. In part two, we have Dr. Keith Valachi, who will share his experience and journey in treating sleep apnea patients. And he's also going to be sharing some very exciting patient case studies. And then finally, we'll have a session at the end where I'll be interviewing both Dr. Remmers and Dr. Valachi and really trying to get their insight into patient-first treatment planning and also understanding about the importance and really how to build relationships with sleep physicians. So before I get into the introduction, there's a couple of housekeeping items that I'd like to review. First of all, our webinar will be recorded, and this will be posted to our YouTube channel within 24 hours. This also has a live Q&A session, so please feel free to submit your questions as you have using the chat window, and we will answer as many as we can in our question and answer period at the end of the session. I have the absolute pleasure of introducing Dr. John Remmers and Dr. Keith Valachi. Thank you guys both so much for being with us tonight and joining me. So Dr. John Remmers is the Chief Medical Officer and co-founder of Zephyr Sleep Technologies. He is a world-recognized physiologist, pioneer and innovator in sleep medicine. And I would like to say he's a pretty good friend of mine. I hope that he would think the same thing. He's a world-renowned expert in the field of snoring and obstructive sleep apnea. He was the first researcher to discover the pathogenesis of sleep apnea and to demonstrate that sleep apnea is caused by the narrowing of the pharynx. And today he's expanded his research interests, and he's investigating neurobiology of respiratory rhythmogenesis, that is a particularly hard word to say, chemoreception, and the pathophysiology of the control of breathing. We also have Dr. Keith Valachi. He is a graduate of Baylor College of Dentistry, and he has also completed a general practice residency at the VAMC in Portland, Oregon. He was the owner-operator of the family general practice in St. Helens, Oregon for 27 years, during which time he developed an interest in dental sleep medicine. 5 years ago, he transitioned to his current dental sleep apnea clinic to focus on managing obstructive sleep apnea and related TMD issues. Dr. Valachi is a member of the ADA, the Oregon DA, Washington County DA, the AADSM, the ASBA, and he holds a diplomate status with the ASBA. I think this is going to be an amazing session, so let's get right into it. John, you've got the floor, and let's move on.
Good afternoon, good evening, folks. It's nice to be with you. I'm John Remmers, the Chief Medical Officer of Zephyr Sleep Technology, and we're going to talk about putting the patient first in treatment of obstructive sleep apnea. We have some problems with oral appliances that you all know about, and I want to review them, though, to highlight them. One is that dentists often pretend that this therapy, OAT, oral appliance therapy, was going to work on everyone, that all patients with sleep apnea will respond to this in a positive, therapeutically satisfactory way. Not so, not so. Furthermore, there is no standard practice that has been developed. Everybody has their own protocol. Some people stimulate cranial nerves. Other have people try to snore. Other folks just do various viewing with imaging. A lot of different places. Most all of it is not evidence-based, and it is the whole field is divided up into a number of schools, and this doesn't engender any respect or confidence in the physician. The physicians know that oral appliance therapy is not equivalent to CPAP. You know that, they know that. Here's the biggest difference is that CPAP treats 100% of patients with obstructive sleep apnea. Oral appliance therapy treats only half of severe apneics, maybe better in mild, but if we talk about just severe sleep apnea, whoa, it's only going to treat half of them successfully. Get their AHI or their ODI into a reasonable range. Blind titration is used. There are numerous visits to clinics, and so the overall patient experience leaves something to be desired. I want to point out to you that oral appliance therapy can be 100% efficacious. It can be equivalent to CPAP, but only if you're using a method that predicts accurately which patients will respond, which will not, and what position of the mandible will be efficacious in eliminating the sleep apnea. MATRx Plus is the only way to go about that. It's the only way. There is no other evidence-based approach that will provide oral appliance therapy that is equivalent to CPAP. And it gets the job done in usually 1, sometimes 2 visits. I'm going to just bring your attention to a group of patients that were a part of clinical trials. So this is not anecdotal clinical practice. This is, in fact, patients in in 5 separate clinical trials. They enrolled in the trial. They received a MATRx test, a MATRx Plus test, and then received a custom appliance set at an efficacious position. So I'm just going to review at 30,000 feet what our experience looked like. But I want to emphasize how they controlled FDA level clinical trials. And these are all patients, except those in red over to the right, who were effectively treated, for whom the therapeutic outcome with a custom appliance was okay, got rid of the sleep apnea. So we are plotting the number of patients here on the y-axis, and then on the x-axis, the amount of protrusion that was required to get the job done, to get rid of sleep apnea. And it goes from percent of protrusion, goes from 0 up to 100% of protrusion. And then over here on the right are those who were not efficaciously treated. Bring them out to maximum protrusion, and still the sleep apnea persists, often without any change from baseline. So these are non-responders. Of the 300 patients, 84, we're talking about almost 25%, folks. That's in the group, overall group. They were mild, moderate, and severe patients. Now, let's kind of have a closer look at that. These are the non-treatable patients at far right. We want to avoid oral appliance therapy in them because it's going to be frustrating and unrewarding. Now, most folks, when they're therapists, I should say, dental sleep medicine therapists, you, the dentist, are going to start the titration, the blind titration of the custom appliance at around 70% of full protrusion. This is typical. You can some back over here and some over here, but most of them are going to start at about 70%. Well, look at what we have right off. We have about a quarter of people, of patients, who are going to be successfully treated, but they're over protruded. And in fact, some of these people, if you bring them all the way out here to near maximum, are going to become therapeutic failures. There's a paradoxical response to protrusion that is commonly seen in our studies. Over here on the right, then, we have people who are now brought out to near maximum. And granted, they will be efficaciously treated there, but you might like to know in advance that your patient who might have some dental issues or TMJ issues are going to require near maximum protrusion to be efficaciously treated. And so in the middle here, we have a group of patients for whom starting at 70% seems to be okay. So this is blind. Everybody's different. That's what the message is from this slide. Everybody's different, and blindly starting at 70% for everybody has consequences which are undesirable. So how do we avoid these consequences? We're going to do it through treatment planning. And this is going to be evidence-based treatment planning that we know will work. Here's what we mean by treatment planning. We begin again with awareness, diagnosis, and get into treatment planning before we undertake treatment and treatment follow-up. This allows the therapist to customize the treatment and select the best options. So that's what we're talking about. You all know about treatment planning, but you may not know about how it works in dental sleep medicine treatment of obstructive sleep apnea. It requires valid predictive information. Prospective. Before you undertake the therapy, you have to know what's going to happen. Here's what we do with CPAP. I want to contrast the challenge facing the dental sleep medicine therapist, you the dentist, versus what happens over here on the medical side. Well, we again begin with the diagnosis, but we move not into just some standards treatment with CPAP. We go into auto-PAP, auto positive airway pressure, titration studies. So for several nights to a week, the patient will first undergo an experiential treatment with an auto CPAP, which is moving the pressure up and down throughout the night, looking for the best pressure, the one that will be optimally treat the patient, and that then is derived by the respiratory therapist. There's a therapist here who is going to select the pressure and select the interface and determine whether or not the patient actually is suitable to move on with CPAP or whether the patient is unlikely to tolerate the CPAP. Once all of this is done, then it's on to CPAP treatment and follow-up. Well, we want to follow a similar program here in oral appliance treatment. We have diagnosis, and then we go into what we call MATRx Plus auto titration study. So back here, it was a CPAP auto titration. We're going to do a MATRx Plus auto titration. Very simple. We, instead of moving the pressure up and down throughout the night as we do with CPAP, we're going to pull the mandible in and out throughout the night while the patient is sleeping. We'll be able to get the evidence that we need from the sleeping patient that will predict outcome. So the patient, based upon the performance of the MATRx Plus auto titration study, the dentist selects the appropriate protrusive position and appliance, and then away we go here to oral appliance treatment and follow-up. So as a therapist, the keys to your success are treatment planning before treatment, deploy methods that are clinically validated and evidence-based and FDA cleared. No more black magic, no more just hunting around in the dark, blind titrations. That is to be avoided. That will not lead to a consistent, confident therapeutic success. And if you do this, then you have the possibility of gaining the trust and respect of the sleep physician. And that's so key. I don't have to tell you that. You know that that's key in the whole effort here. So certainty, that's our goal. No guesswork about treatment configuration. If you have certainty, your patient will be happy, you'll be happy, and the referring physician will be happy. So here's how MATRx Plus does this. You have a bedside tablet, a little computer that's mounted on the body, wirelessly talking together, and they are in turn talking to a remote computer. The test, it's an overnight test, will accurately predict who and how to treat. Here's the results of one clinical trial, most recent clinical trial. And in this trial, we had 60 some odd patients, all of whom received a MATRx home sleep test. So carried out in the home during sleep on all of the patients. The results of that test indicated that some of them were predicted to undergo therapeutic success with a custom appliance. So if we make them appliance, the test is saying if you make a custom appliance for these people, they will have a good therapeutic response. But there are others, predicted failures, for whom the therapy, oral appliance therapy with a custom appliance is not going to get the job done. People are going to be left with sleep apnea. So these are predictions. We predicted failures or predicted successes from amongst the total population in this group of patients. So just look at this. Let's look at the group that was predicted to undergo therapeutic success with a custom appliance. Well, at baseline, the values of ODI, that's like an AHI. It's a bit more reliable and a bit more predictive of risk. They go from 10 up to 115. So we have the whole spectrum of people. And this is what they were like at baseline. Then we put a custom appliance, built a custom appliance for them, put them in the mouth, and they all had an ODI less than 10. That's our criterion for therapeutic success. And the mean value was 5.8. So every one of the patients who were predicted to respond did respond. They all had a good therapeutic outcome. And on average, it's very nice. Over here with the predicted failures, it's a little bit different. The red lines are the ones to focus on right now. Their values go from 20 up to 110 again. And these people are predicted not to experience a good outcome. And so here they are at baseline. And when you look at the outcome, you move over here to the right. Here they are at outcome. And all these people who are identified as poor, as unlikely responders, as not favorable candidates, they all fail. You can see they all go across. Some have a bit of an improvement. Some of them have no improvements. Some of them begin at 100 and they stay at 100. So we have We have the correct prediction of therapeutic failure in these folks with the red lines. And then in 4 patients, we incorrectly predicted that they were going to be failures, therapeutic failures, because look, they actually barely made it, but they did get under 10. So they were therapeutic successes. So nothing's perfect. We have this incorrect prediction, but the overall prediction ability of this test far outstrips anything else that's ever been seen before, ever been used. And it's clinically available. It is useful in the home. It is easy to use. So now we'll just look at what I call certainty. And this is the essence of certainty. It's that all the patients who are labeled for you prospectively to be therapeutic successes, every one of them is going to experience a therapeutic success. And the mean value for their ODI is going to be 5.8. So it's a really a very comfortable position. Now we can say, well, how good is the planning or for treatment planning, the accuracy of predicting an efficacious position of the mandible so everybody who is a therapeutic success gets a predicted position where they will experience that therapeutic success. Some as low as 30, some as high as 100%. Now, that's on the prediction is on the x-axis here. On the y-axis is the actually observed therapeutic position. This is how much protrusion had to be undertaken in order for the patient to experience therapeutic success, to have an ODI less than 10. And you can see if you lie on this line, well, everything's pretty hunky-dory there. We are just fine. The predicted value was, in fact, a successful value. We have 6 patients, or 15%, who were not successful at the predicted efficacious position, and we had to pull their mandible, advance their mandible a bit more, a couple millimeters more. So again, we have good accuracy, 85%, it's spot on. With the MATRx Plus, 75% of your patients will require only one visit to get the correct position. So your blind titration, which everybody else engages in, that's not using MATRx Plus, is going to require at least 3 visits. So here it is. It showed 75% of patients get the job done with one visit. That's the visit that's required just to position the appliance on the teeth, and then the patient goes away and is successfully treated at that position. And then you can have 2, 3, or 4 visits in some patients that require some additional protrusion. If you go right to target, things work out just fine. The idea that you must slowly approach an efficacious position seems not to be the case if you know where to set the mandible. So if we can insert at target everyone at the predicted efficacious, we can do that for everyone where the protrusion is less than 80% that's required. So for 0 up to 80%, it's only you set the patient immediately at that target, but the patient tolerates it fine. If you're between 80 and 100% for your efficacious position, then in fact you will require some additional protrusion and some moment for some time for habituation. So now we're going to close by telling you about the real surprise here. Zephyr's releasing an improved MATRx Plus, an enhancement to MATRx Plus. But what an enhancement. We're going to control the mandibular positioner throughout the night, move the mandible in and out, only using information derived from O2 saturation. No airflow measurement is required. So no cannula prong sticking up the nose. And these are prone to get dislodged, so the patient has to be alerted and awakened and told to reposition the cannula and so on. Huge a bother for the patient, a disturbance of sleep. So we've now got the product, and it's been cleared by the FDA, that doesn't use airflow. So we are going to predict the outcome and predict the efficacious position based only upon the O2 saturation. There will be no change in the diagnostic study. That will stay the same. The diagnostic use of MATRx Plus will stay exactly the same. But for the Theragnostic study, where we're predicting the outcome and predicting the required position of the mandible for an efficacious response, that's going to be done essentially with an oximeter. You're going to be using an oximeter and the trays that you as a dentist have built for that patient or that particular patient, and that's all it boils down to. So it becomes a much simpler test, we feel. This is going to be available, no hardware change, just over-the-air change in software that happens next week. So we feel that will improve patient experience, increase the comfort, make for simpler setups and fewer sensors. Very important, reduce nighttime disturbances for the patient and incomplete studies that occur because we have airflow alerts, and reliability and accuracy are not compromised. We have in our last clinical trial that was reviewed by the FDA, and the device is cleared by the FDA based upon the results of this clinical trial, 97% accuracy in identifying responders, 89% in identifying the efficacious position of the mandible. So it's good or better than MATRx Plus. So we say, let's put the patient first. Let's help more people. We're going to drive practice referrals because of our relationship that is built with the referring physicians, increase patient confidence, dentist confidence, team confidence. Everybody's going to have more confidence because we know how things are going to work out. No blind adjustments, higher therapeutic compliance, we think, improve relationship, most importantly, with the sleep physician, and then finally, decrease time to treatment. The benefits of treatment efficiency, of course, you know well. We can treat more patients, save money on unnecessary titration visits, increase your production, drive referrals with real excellence in patient experience, and of course, avoid bringing patients into the office during a time of COVID and other problems with aerosols. I'm going to end here and say thank you. I'm turning it over to the presentation over to my friend and colleague, Keith Valachi. I think you will enjoy his presentation very much.
Okay, thank you, John. Get this going here. All right, I am assuming everything is looking good here. So I appreciate the introduction, and I want to start by saying that I have 0% financial interest in MATRx. I'm just a satisfied user who feels that this technology can help get more dentists involved in treating sleep and get some improved patient outcomes. So I guess I'm going to talk about me and my MATRx, and we'll get started here. So I first learned about MATRx when I was a general dentist practicing in the small town of St. Helens, Oregon, just north of Portland, situated right on the mighty Columbia River. And it was just that kind of small town practice that when I was in dental school, that's kind of what I wanted. I just wanted to help people have improved lives through improving their dental health. This is where my practice was, just a humble little practice on the main drag heading down towards the river. I shucked a lot of teeth in that little building though. But one of the nice things about being a general dentist is that you can kind of pick and choose your procedures, and I had some interest in other areas that led me towards MATRx, which I'll get to in a second. But St. Helens is named after the volcano, which we can still see a little bit of across the river in Washington State. And really, its claim to fame is that some of you may know that some of the I can't remember the name of the movies now, were shot there, but they also have this annual Halloween Town Festival, which is a big draw, at least locally. It was the Twilight movies that were filmed in St. Helens. So I was going along as a general dentist in this town, and I had always kind of had an interest in TMD. So I'd been to a lot of classes with a lot of different gurus, and then at one point I luckily landed in a class with Dr. Barry Glassman. Some of you may be aware of Barry and that he had a sleep and orofacial pain practice before it was cool in Allentown, Pennsylvania, and he's really a remarkable educator and quite the storyteller as well. So it was Dr. Glassman who really kind of codified for me the idea, which was revolutionary at one time, but is now really accepted, and I'm sure a lot of the attendees already know this, but that there is this big connection between sleep bruxism and sleep apnea. As a general dentist, this is how I treated sleep bruxism, was just a night guard, basically. And how I wish I could go back and take those night guards away from people and have them go take a sleep test instead. But then I had this idea too that a lot of you probably share, that how cool would it be to be able to use my dental skills to help manage a complex chronic medical condition like sleep. So I started taking some sleep courses and started treating sleep in my general practice, and I ran into a lot of the same challenges that probably many of you have had with getting patient and staff buy-in. But also I was really having a lot of difficulty understanding the varied responses I was seeing to oral appliances in my patients, where some patients would respond very quickly and did quite well with their oral appliances, while others were really struggling with the process. And I really struggled to understand why that was happening, and it was a source of frustration for me and a source of disappointment for a lot of patients who just didn't seem to be getting better. So it seems that the sweet spot with oral appliances is not always easy to determine when you are dealing with such a complex medical condition like sleep, complex phenomenon like sleep. Excuse me. So I remember asking Barry kind of a rookie question, which was, if we get to the sweet spot, do patients respond, and does the airway respond really quickly like it does with CPAP? And his answer was something along the lines of, well, of course it does. We know this because of the MATRx data. So that was my first introduction to MATRx, and it intrigued me. But of course, he was talking about, at that time, the in-lab version of MATRx, and we didn't have any sleep physicians in St. Helens, let alone anybody doing MATRx. So it kind of left my orbit for at least a little while. So fast forward a few years, and I transferred from St. Helens to practicing here in Portland, Oregon. Here is where my practice is now in Portland. Portland is famous for its beautiful environment. We're really proud of our natural beauty, including iconic Mount Hood, which is just east of town here. We're also kind of famous for some of our professional sports teams like the Portland Timbers and of course the Blazers. And lately we've gotten a little bit of notoriety for some extracurricular civic gatherings which have been occurring, which has gotten us in the news quite a bit here lately. So as I was starting to develop this brand new practice a few years ago, I dutifully made my rounds to as many of the sleep physician offices that I could in town. And there was actually one office here in town that was using in-lab MATRx. So we ran a few cases through their system, and things were going pretty well. But oh my God, what a clunky process was that. I mean, first of all, obviously the patient would have to get diagnosed, and oftentimes they'd gone through their CPAP treatment. They were either intolerant or non-compliant. They actually stopped using it. Then they would have to be referred to a MATRx dentist for MATRx trays. We referred them back to the sleep physician, where they would have this in-lab test done. The sleep physician at that clinic would make the determination if the patient was an oral appliance responder, and then they'd get sent back to the MATRx dentist. And with all of that and the inevitable scheduling issues, it would take weeks and sometimes months for the patient to actually get back to us and be ready to start oral appliance therapy. So now we have MATRx Plus, and this really streamlines the process, and it puts the technology in our hands, the hands of the dentist. We are a group of professionals that thrives on high-tech stuff, so this is kind of right in our ballpark here. And because it's a Theragnostic test, that means that it can actually be dispensed by a dentist, as opposed to in most places, at least in the US, where dentists cannot dispense home sleep tests, especially for diagnosis, obviously. So MATRx has been a huge benefit to my practice, both in case management. I'll get to a little bit more on that in a moment. But also because it has, I think, raised the credibility of our practice in the local sleep medical community. You guys all probably know, the attendees all probably know, that there are still a lot of sleep physicians and nurse practitioners and PAs and whatnot, the sleep medical providers, who disbelieve that oral appliances can be effective for anything other than mild sleep apnea. And in a lot of cases, they're going to put a CPAP even on those mild cases. So it really helps when we communicate with physicians about technology like MATRx Plus. I've shared the MATRx Plus study with physicians, but especially if we can communicate back about successful treatment cases, that really helps to raise their estimation of the technology and what we can do for their patients. So for me, this has been both a great clinical and a marketing tool. So I think back to my early days of trying to treat sleep, where I was really struggling with some of those cases, and I can only imagine how much easier that would have been if I hadn't seen some of those early failures. Now, I know, obviously, a lot of us, we learn more from failures than from successes, but how many dentists who tried to treat sleep in their practices quit because of those early failures that they experienced? And then who really is the ultimate loser in that scenario? And I think the answer is it's all those patients who never got treated because the dentist didn't continue down that road. So I think this has some value to help more people as well as help our practices. So having said all that, let's take a look at a few cases. So first case I'm going to review with you is of a 73-year-old female with a significant medical history, including severe sleep apnea, snored a lot, and she was really having difficulty with her CPAP. Not an uncommon scenario. She was taking her mask off most nights after just a few hours of use. So she was really trying to use CPAP, but she was not really very successful with it. So she had her polysomnogram of severe sleep apnea. There is a significant positional component to this case, which turned out not to be significant in this case, and some moderate but still significant desaturations. So we completed her MATRx Plus Theragnostic study. She was predicted to be a responder at full protrusion. So this is a case that some people would maybe consider to be really challenging to approach. We're already dealing with someone with a significant medical history. She's older. We've always been told that oral appliance therapy works better on younger patients. And oh my goodness, we've got to get her jaw all the way forward. How on earth is she going to tolerate that? There's some idea, some theoretical thinking out there that a lot of times the side effects that patients experience with an oral appliance is because we have not gotten the appliance to the sweet spot. And so the airway's not open. There are bruxism events associated with the apneas that are still occurring. And the patient's fighting their appliance now. And that may be part of the reason, at least, that some side effects develop. So for this patient, though, we delivered her appliance and we rapidly titrated her right to full protrusion. And she tolerated that aggressive jaw position really, really well. We did a home sleep test. I'm still kind of in the mode of proving to my physicians that this works. So I'm still doing some preliminary sleep testing, and the preliminary results looked really good with improvements in her numbers across the board. So as I do with all my patients, I referred her back to the sleep physician for consideration of further sleep testing. She is now, though, using her oral appliance as sole therapy, and you can bet that this doctor, who I had not worked much with before, received a follow-up phone call to review her case, and they came away, I think, pretty impressed with what we've done for her. When we look at the MATRx reports, this kind of shows that this really isn't rocket science. I really enjoy doing MATRx for a couple reasons. One is my staff does most of the work, which is great. And the second is that it provides some very simple and very easily understood reports. So you can see right here in this, it gives you this little graph and it shows that she is a responder. It's to the left of that middle line. Basically, the farther to the left the study result lands, the higher likelihood I think that the patient actually will be a responder when we do follow-up testing. And then there's a lot of data that comes with the MATRx. You can actually see the traces here that show all the same things that you're used to seeing in home sleep tests. That second line there with the blue squiggles and the yellow lines, those are the apnea events. And I'm not trying to interpret sleep tests when I look at these, but I can just visually tell that that does not look like an AHI of 35 or a severe sleep apnea case. There are still events, but we can tell that that's really a greatly improved response. So second case, this is going to be a 68-year-old male, also with a very significant medical history. This patient came to me actually as someone who's CPAP compliant, but you guys have probably heard this before too, that he wanted an oral appliance because CPAP's a hassle, and he also wanted one for traveling. So I don't know about some of the attendees, but with our traditional oral appliance titration techniques, where we have to actually have the patient wear just the oral appliance and kind of compare how do you feel with the oral appliance compared to how do you feel with the CPAP. And if they don't feel the same, they've got to go back on CPAP, and then we do this back and forth. And it's a very, again, clunky process that can take a long time, and it can be very confusing because they're using their CPAP at least intermittently during that time. So great use for MATRx. We ran him through the MATRx test. Sorry about that. His sleep test results also severe sleep apnea. And look at those DSATs. I mean, he's spending 56% of the night under 89%. There's a lot going on the pulmonary level here. So we did his MATRx test, and he was predicted to be a non-responder. So that's not great. Obviously, the patient was very disappointed initially, but does this outcome really represent a failure? And in my estimation, the answer is definitely no. And the reason is the patient did not then have to suffer through a needless and a likely very arduous oral appliance titration process just to find out that the darn thing wasn't going to work for him at all. So his matrix report looks like this, way to the right on the non-responders. So pretty high confidence that that answer is correct, just with a visual. And then when we look at his trace, look at all those DSATs and look at all the yellow lines on there. He was having apneas just right and left, and it's pretty obvious there was no way this guy was ever going to respond to an oral appliance, even at full protrusion. So pretty useful to weed out those patients who are not going to do well with the oral appliance at all. Third case, and this is the last one, a little bit younger patient, not as significant of a medical history, but he could not use CPAP at all anymore because he had aerophagia using CPAP, which does not sound like a fun experience trying to sleep with your stomach filling full of air. So the question might be, in a case like this, why even bother with something like MATRx in a case where the patient's not using CPAP at all? I mean, even if it helps him a little bit, isn't that a positive outcome? And I can understand that argument to a certain degree. But let's look a little further here. His sleep test showed, again, severe sleep apnea, huge supine or positional component here, and significant and again, at least moderate desaturations across the night of the study. Here's kind of the crux for me here. Has anybody ever had this happen, where the patient comes in saying, yeah, my sleep physician told me I can go ahead and try an oral appliance, but it's not going to work for my severe sleep apnea? So what does that do to the patient's expectations about what we can do for them? This really relates to a quote that I just heard from my colleague Steve Carstensen up in Seattle. I think this actually came out of the Principles and Practice of Sleep Medicine textbook, that there is a high perceived benefit. It's the first and perhaps the most important step on the road to therapeutic acceptance and utilization. So when we have a patient coming in who's already had their head filled with this idea that an oral appliance probably isn't going to work for them anyway, I think that's a real roadblock to long-term success for the patient. So we have an answer to this type of scenario now, which is we do a Theragnostic MATRx Plus study, and lo and behold, the patient was deemed to be a responder. Pretty aggressive position, but still deemed to be a responder. So now we can have the patient go into treatment with a higher level of confidence that he's actually going to have a good therapeutic response. So this case was a little bit interesting though. We did our preliminary sleep testing again, and again, a really nice reduction in his numbers across the board. But in order to get there, this was actually the second or third night of testing that I did with an HST. We had to bring him forward a little bit extra beyond that target mandibular position, because if you recall, if you see back on that supine number, he just could not tolerate positional therapy because of shoulder pain. So if he had been able to tolerate positional therapy, would it have been possible that that target mandibular position would have been more accurate? I don't know, but I suspect that that might be true. Again, as always, the patient was referred back to a sleep physician for consideration of any more testing that they want to do. I just leave that up to the sleep docs at that point. So his report looked like this. Again, looks good as far as being far to the left of the success line. And you can see that he was predicted to be a responder at about 2 millimeters shy of full protrusion. We ended him at about 1 millimeter shy of full protrusion. And again, with the actual testing here, this is a little bit more interesting because you can see there's still a lot of events here. This was the first night of his MATRx test, but if you look at the bottom there, where you see the light blue and then that kind of light purplish pink, that light purple is supine, and most of those events were in supine. Again, this is why, even though this isn't rocket science and it's not that hard to do, MATRx doesn't do everything for you. There's still some clinical judgment involved here, which is why we ended up moving him a little bit more forward than we otherwise would have. So those are the cases, and just kind of wrap this up, as a practicing clinician, these are some of the benefits that I see using MATRx Plus. Obviously, there are great benefits for the dentist, and I think Dr. Remmers did a great job reviewing how this makes our treatment flow much easier and our predictability much higher. which as you treat more and more cases, you will really come to value those benefits. Obvious benefits to our patients because we can give them a higher level of confidence that this treatment is actually going to help them, and that can help improve long-term success with these patients. And for those of you who are just getting into treatment, I think this MATRx really can kind of form a bridge between where you're at now and your ability to become a successful dental sleep medicine provider, both as a clinician and as someone who can attract more referrals to your patients by showing our local sleep medical community that oral appliances can be successful for more than just mild sleep apnea. And because we will also get some word-of-mouth referrals from our patients who are very satisfied with their care. So that's about all I have for you here tonight. I really thank you for your attention, and I appreciate the opportunity to be here.
Thank you so much, Dr. Valachi. That was amazing, sharing your journey, and those were some great case studies. And Dr. Remmers, thank you for sharing the technology advancement. That's exciting. I mean, that's exciting for us and really exciting for our customers. So what I'd like to do now is open us up for a bit of a discussion. And I think really important to focus on, Dr. Valachi, on that journey that you had with the sleep physician. And you mentioned it a couple of times. I wrote some notes here that excuse me, physicians telling patients OAT not going to work, that they maybe even disbelieve in OAT. And so how do you go about and relate to the sleep physicians in your community?
Well, that's a great question, and it really depends on the level of relationships that you may have already built with the sleep medical community. So by the time I started using MATRx, I had already had some really good relationships established with some of the sleep docs here in town and not so good relationships with others. So I approached it a little bit differently based on what my previous relationship was with those physicians. Some I'm able just to pick up the phone or drop them a text, and I can talk to them about these things. Others I approached more cautiously. I sent them some emails, attached the study to the emails, encouraged them to contact Dr. Remmers, who was very generous with his time and talking with physicians and that type of thing. For people who don't have relationships with sleep physicians and they're trying to develop those relationships, I think MATRx really brings something positive to the table that you can take to those initial meetings that you have with those doctors and other providers, in that you can show them that, hey, I'm really only interested in treating the cases that I know are going to succeed. Any case that looks like it's a non-responder or even a borderline case maybe, I'm not going to try to treat them, and that may enhance your ability to develop a really quality relationship with those providers.
Yeah, I know that we've definitely seen that a lot in showing the way that the technology works, and really using that as a benefit along with your clinical judgment, and using that kind of as a springboard to drive further into building those relationships.
Yeah, I'd add to that, Oren. Sorry to interrupt you, but
No,
physicians love data, and the data on MATRx is really good. The studies they're all peer reviewed, and the data is really strong. So I think that there will be a little extra level of respect that you can show such profoundly positive clinical data.
Yeah, I mean that actually leads me to another question about, so when you're sharing data and building, fostering and building these initial relationships, is it papers that you're sharing? Is it clinical data? I mean, what are the tools that you're using to be able to grow that relationship?
Yeah, I think it's really important for us dentists to communicate effectively with these sleep providers. And my primary means of doing that is physicians, they love faxes. It's still part of the medical, the way of doing things. So we always send letters via fax to our physicians when we start treatment, or if I start a MATRx case. And then physicians that I don't know that well, I'll pick up the phone afterwards. Once a physician has gotten a letter from a dentist, that opens the door to allow you to call them up and say, hey, I'd like to talk to Dr. X about a mutual patient. And a lot of times the doctor will come right on the phone, or the staff will say, oh, he's in with a patient. Do you want me to pull him out of the room? By the way, I always say no, don't pull the doctor out of the room. Just here's my cell phone number, have to give me a call. But now you've got that ability to have that personal conversation with the doctor, and then you can go into a little bit more about some of the science and some of the data. I do have one case in particular where MATRx improved my relationship with a sleep physician. When I made my rounds, I had one sleep physician that we just butted heads from the get-go. We just never could quite get a relationship going. I had 0 referrals from this physician for several years, and I kept trying. It was only after I brought MATRx to the table and that we actually started to develop a working relationship. And now I'm getting referrals from that doctor, some specifically for MATRx. So again, I think that raised my credibility in that doctor's eyes.
Mm-hmm. And along those lines, when you're seeing these referrals from your network of sleep physicians, are some of them specifically looking for you to do MATRx versus not, or specific ways, or are they leaving that up to your clinical judgment?
I am getting some that are specific referrals for MATRx, but that's not the lion's share of them. Again, it kind of depends on the relationship level with the physician, but most physicians that I work with now that we've kind of fostered these relationships with tell me they trust my clinical judgment. That doesn't mean I don't communicate to them, especially on these severe cases. Hey, we're going to do a MATRx first, just so you know. I'm not going to just jump in and toss an appliance in this patient. And I think they appreciate that level of communication.
Mm-hmm. So that's excellent. I have a question for both of you, and this is something that I've experienced when I'm speaking with different dentists, and this has to do with the definition of sleep apnea. So today, the definition of sleep apnea is an AHI greater than 5. And the MATRx Plus, as John spoke about, is using ODI to make the determination of whether or not a patient will be a responder to the therapy. And we're using an ODI of 10 as our threshold. So I guess this is kind of a two-part question. One, Dr. Valachi, I'd like to hear about what happens in practice when you've got patients in that, I'll call it gray zone, where they've been diagnosed with obstructive sleep apnea. That's not gray at all. But what do we do there? And John, I'd like to ask you, why 10?
Or I didn't quite understand the question. What do you mean the gray zone again? So
the MATRx Plus, that predicts for an ODI greater than 10, or less than 10, sorry. So what's happening between our patients that have an AHI of 6 or 7, have been diagnosed with sleep apnea, what are we doing? What are you doing there clinically?
So I don't typically use MATRx on cases with ODI or AHI under 10. We know that we have a higher success rate with mild sleep apnea, and I tend to reserve it, partly because I only have one MATRx so far, but I tend to reserve it for cases where we've got a moderate or severe case, or for patients who ask the question, which many of the attendees may have heard patients ask, can you guarantee this is going to work for me? Usually the answer is no. Well, I still can't guarantee it even with MATRx, but I can give them that higher level of confidence if we use MATRx. So I have cases that I've done where we have high HIs but low ODIs. I still use it in those cases because again, we can see that visual with the report, and I can kind of get a sense that yes, the AHI is significantly reduced as well. But typically under 10, I'm just doing the traditional method of titration.
And John?
The first is kind of a fundamental God and motherhood concept. In medicine, we consider sleep apnea a medical disease. We make diagnoses, and so a diagnosis means that there's something wrong, and the first, the basis for the diagnosis, the numerical diagnosis of sleep apnea being an AHI of some value, that is implicit in the name, actually. It's sleep apnea. So when you go to sleep, you either don't breathe or almost don't breathe. So to talk about AHI in that respect makes perfect sense. So an AHI is an index of how often you're not breathing, and so that doesn't bother me. Seems like a good place to start. And we have to pick a number. And different people pick different numbers. The CPAP companies wanted us to pick a number that was as low as possible, so more people would be diagnosed with sleep apnea, and that would foster their business. Well, they didn't realize how many people were going to get caught in that if less than 5 was the criterion for normalcy. So now we're kind of overrun with patients, and there are some studies that show in some locations 85% of people have sleep apnea by the AHI greater than 10 being sleep apnea. So there is a question of what's this all about? It's not reason to reject the diagnosis, but it's to say we picked an arbitrary one that was probably too low. The way we normally identify a value or a cutoff above which somebody has the disease is exemplified by high blood pressure. How did we arrive initially, whatever it was, 50 years ago, with the idea that if your diastolic blood pressure was greater than 90, you had high blood pressure, you had arterial hypertension? How did we do that? Well, it came from epidemiological studies in which lots of people had their blood pressure measured, and then we watched what happened to them, and the people who had a diastolic blood pressure over 90 were prone to get strokes. We said, oh, maybe that's then what we should define the disease as, diastolic greater than 90, and we should treat people with diastolic greater than 90. So we do have that data, actually, similar data for our definition of sleep apnea. And if you look carefully at the data, it's a value of 10 is better than 5 as defining where the increased risk for heart attacks and strokes begin with sleep apnea. And in fact, AHI isn't the best definition, and ODI is a better one. The body seems to care more about the drop in oxygen than it does about transient 10 seconds, 15 seconds cessation of breathing. And that makes sense. So while I'm not necessarily suggesting that we change everything, but I'm certainly saying the whole field is opening up to the notion that an oxygen desaturation index may be more relevant in predicting who's going to have a cardiovascular event in 10, 20 years. And in addition, a value of 10 might be a more realistic one than 5. There's a whole concern in addition about what does severe sleep apnea mean? Do we really mean that if you have an AHI greater than 30, you should be called severe? What does that mean? That's another story that we'll come to later, called Beyond AHI is the name of that lecture, but it is also worth taking up. Thank you for that.
Excellent. Thank you, John. Thank you, Dr. Valachi. Thank you so much for this discussion. This was amazing. We are bumping up to our time here, and I want to be very respectful of everybody who has joined our webinar. So I will make it aware that we are going to have a very quick Q&A session. And like I mentioned at the beginning, our webinar will be recorded and uploaded to YouTube within 24 hours. So just quickly before we get into our Q&A session, there's a couple of things that I would like everybody to be aware of. There are these great promotions that we're running until the end of the year. First, for new or current customers, we are offering a $2,500 manufacturer rebate on all MATRx Plus systems purchased between now and the end of the year. And second, for current customers, if you're scheduling a sleep theragnostic or a combined study between October and the end of the year, we will replace all of the disposables that you've used at no cost to you. Our goal here is really to support our customer base at this extremely difficult year and time that we're all facing. Also, for those of you who are interested in learning more, please feel free to contact us on our social media channels or via email. So there's a couple of questions here that I've got in front of me. I will get them out and we'll go top down. So Dr. Valachi, I think I'd like to start here with you. Do you think appliance design impacts the effective target protrusion? So the effective target protrusive position.
It can, in the sense of if you were to start with a very conservative start position. Let's say you had a total protrusive range of 12 millimeters, and let's say you started at 5 millimeters and you use the dorsal device, which only has 5 millimeters of titration. You can get them out to 10, but what if that patient doesn't respond till 12? Now that device isn't useful to get them to 12 without changing something, which usually means sending it back to the lab. As far as I understand, though, there are no studies that show that any one device is any more effective than other devices in any other device as far as improving the airway. To me, it comes down to choosing the device that gives me enough protrusive range, and also a device that respects whatever wear patterns I see in the patient's teeth. Other than that, I don't think the actual device affects what you just asked about.
Wonderful. And another one for you. How do you transfer the precise position from the MATRx Plus study to the custom appliance accurately?
So that's a great question, and I do like that streamlined process. So when we do a matrix case, I make the assumption, because most people are going to be responders, that we're going to have a responder. So on the day we do we custom fit the matrix trays, I'm doing the digital scan and a bite registration for the patient. Because of matrix data, I am more conservative with my start positions than I used to be, because I know there are going to be some patients who are going to respond at a very conservative jaw protrusion position. So I'll start that bite registration at a very conservative position, and then I just transfer that data to what the matrix predicted target value is, mandibular position is. So let's say I start a case at 40% protrusion, say 4 out of 10 millimeters, and matrix says they're going to respond at 2 millimeters shy of full protrusion. I know I've got 4 more millimeters to adjust that device forward to get to that target position. The great thing is that for most patients, we go right to that position, and it really does cut down on the amount of time to get there.
Excellent. John, we've got a couple questions here. These are about the new technology advancements. So do the nasal cannulas still need to be used with sleep studies?
You bet. This is called a level 3 study that we're talking about, usually referred to as HSAT, Home Sleep Apnea Test. And that level 3 study implies that you're going to measure airflow, oxygen saturation, belt, and body position. So that's a very clearly defined and I think very well substantiated test. We have lots of evidence about its predictability, how accurate it is. So we don't want to change that. But an example would be, look, if you want to try to determine whether somebody has a central sleep apnea or an obstructive sleep apnea, you're going to need the airflow and you're going to need the belt. And you're also going to need a pro, a sleep doc, to look at that data. This data is much harder to correctly assimilate and interpret than a polysomnogram, believe it or not, because we don't have a lot of data, but a pro can do this for you, and we don't want to infringe on the quality of the diagnostic process. Not to say that an oximeter isn't useful, a simple oximeter isn't useful in certain instances, but we're not at all interested in degrading our ability to identify whether somebody has sleep apnea or not, the type of sleep apnea it is, and in addition, how severe it is. But now, when we can move over to predicting, this is something very different. We're not trying to any longer saying, oh, this person has severe sleep apnea or something, or of a certain type. We already know they have obstructive sleep apnea. That means their ODI is greater than 10. And so we know that now. The MATRx Plus test is simply devoted to trying to help you understand whether this patient is going to be a favorable candidate for oral appliance therapy and where you should set the mandible. And it does both of those very accurately. It's really good at doing both of those with oxygen only. It was good at doing it with oxygen plus airflow, but it turns out, you see, that if you have a disturbance of airflow, of breathing, you're going to have a disturbance of oxygen. So we figured out how to do it so that we just use oxygen alone. And of course, if you can do something and make it simpler and more comfortable for the patient, then you clearly want to go down that road.
Excellent. Dr. Valachi, have you noticed any long-term TMD symptoms with protrusion targets? So I'm assuming this would be high protrusion targets.
Not really. And I think that relates back to the idea, I won't say that I haven't seen any, but maybe not as many as people would expect. And I think that might relate back to that idea that a lot of side effects, especially comfort side effects, may come from patients fighting their appliance because they've got this piece of plastic in their mouth that's maintaining a certain jaw position, but their airway is still struggling to open. So the patients that we've taken to those full protrusion points really haven't had many problems with them. It's been really a pleasant development or something pleasant to see. So yeah, fortunately, haven't seen that much.
Yeah, and this is true in our it's true in our extensive clinical trials. That was noted. It was shocking when we first realized that, wow, you can put a patient at a rather advanced mandibular position and they're okay with it. And that was because probably they're being effectively treated at that position. So I'm pleased to hear, Keith, that it's held up in your experience. But that's what we observed first in MATRx, then in MATRx Plus, and in several studies with MATRx Plus.
Now, I will say that I tend to see more jaw discomfort in cases that I'm titrating the traditional way, which is let's try to use our black magic or traditional technique to try to find the sweet spot, especially early in treatment where the patient is kind of struggling with the device. And we talk to the patient about, hey, this sounds kind of counterintuitive, but your jaw may get better the further forward we go. And lo and behold, in a lot of cases, we advance another 2 or 3 millimeters and the jaw pain goes away. And then we do the follow-up sleep test, and yes, we've got the right position. It's kind of interesting how that happens.
That is fascinating. All right, so here is our final question. Dr. Valachi, again, this is for you. Have you done any comparisons using MATRx Plus as far as the method you're using to position the mandible? So this would be referring to George gauge versus a phonetic bite.
No, I don't use phonetic bites for sleep patients. I usually just use the George gauge. And particularly with MATRx cases, it's all about the numbers. So I'm just using the George gauge to get my start position and then altering the position of the device based on what the MATRx numbers tell me. I could expand just a little bit on that previous question, which I thought was really an excellent question. How do I relate the numbers? The only issue I can see with the bite registration, the way I'm doing it, is say if I do a bite registration at 40% of protrusion, and then the matrix comes back that the patient one needs 20% of protrusion, I've got to do a new bite registration. So I'm thinking I might start taking 2 bite registrations for my patients, one really small, and then one kind of at that 50% rate, and then I can tell the lab which one to use to build the case.
Right.
So I learned something tonight too. That's pretty cool.
That's fantastic.
Great idea.
Well, thank you both so much for participating in this discussion. This was fantastic for me, and I would like to thank everybody who joined us for this evening. Thank you so much. We will be hosting another webinar on Thursday, December 10th at 7 Eastern with Dr. Sharkande. He will present sleep and total health, why and how to implement a predictable sleep and airway management program. There will be registration details that will follow in follow-up emails. Once again, I really would like to thank both Dr. Valachi and Dr. Remmers. I really appreciate the time that you've taken out of your days to speak with us, and I really appreciate the discussion. This has been fantastic. Thank you both so much.
Thank you.
Thank you all for attending.
Good night,
Talk to you
everyone.
later.